Well, my thanks to Omics. Yeah, and this is my Twitter, and this is my email, okay? Yeah, I intend to spend here at most 20 minutes. I would ask Ricardo, it's fine for you, Ricardo? When I reach 15 minutes to raise your hands like this, okay? Yeah. Just to start with, I have no conflicts of interest with cardiologists or nephrologists, even because I'm both of them. So this is no big deal for me. But yeah, about the ex-president Franklin Delano Roosevelt, I've heard this story in Brazil, that he had a lover, and he would spend almost every weekend in Florida with her, in a beach of Florida. And 1 or 2 days before, he would have a political meeting at his house in Florida with her. And he had a team of doctors that said he was in perfect health. Then he had a stroke and died in the hands and the arms of his lover, okay? I would not regret the way he died, okay? But that's life, that's hypertension. We are talking here about the most common disease and the most common cardiovascular disease. But this is true. Eloisa is laughing there, but this is true, okay, Eloisa? That's the way the ex-president of U.S. died in Florida, okay? And doctor said he was all right. So to be surrounded by too many doctors should not be something very good in your life, okay? So let's move on. Well, we are talking about a disease that has more than 100 medications on the pharmacy to sell. When we have a disease with more than 100 medications, it means that we know almost nothing about this disease. You see, we need to get along with that, with our ignorance about hypertension. Okay? And when we are humble enough, things get better, because we need to be humble in life many times. Yeah, so this is the World Health Organization MONICA project, you see? Because we talk too much about hypertension, the most common disease, the strongest cardiovascular risk factor. But we do not talk too much that the cardiovascular mortality in the whole world, in a global perspective, plummeted since the late 50s and started to decline since the 60s. And hydrochlorothiazide was getting onto the market only after 1967, when the mortality of cardiovascular disease was already declining all over the world. People don't say that. Pharmaceutical companies don't like us to know that. So the World Health Organization organized this MONICA, charming name, right? MONICA project was on 28 countries in Europe and Asia, mostly, to see what was going on. It was a populational epidemiological study. It's a kind of different epidemiological study to see what was going on. Because until today, cardiovascular mortality is going down, not in such a speed because of the epidemics of obesity and diabetes, but it's still going down. And we don't know for sure why. not because of hypertension treatment, because the influence of the tons of drugs we use for hypertension on that is very small, okay? There are good data, okay, about this. And this study showed that there must be other reasons why there is a continuing reduction in cardiovascular mortality since the early 60s. I hope I'm speaking English and not Portuguese or Greek or Italian here, okay? We don't know. So let's look at that. This is a summary from the Monica study, but nobody talks about this. Pharmaceutical companies, they would hate you if you talk with them about the Monica study. Yeah, you see, high blood pressure is here, very small decrease in blood pressure. You see, 28 countries, they are not similar to each other. Very interesting. One of the richest countries in the whole world, the UK, has one of the highest cardiovascular mortality compared to other countries. Nobody knows why this. I don't know, at least, okay? But interesting. So what the Monica study showed, I see a medical student here looking very curious with this. That's curious, really. You see that the socioeconomic status, maybe because of the blue lights or something other confounders, we don't know, seem to have a stronger influence, much more than the tons of blood pressure medications for that. And so this is still going on. It has 20 years, has a very good homepage, and with very trustworthy data. I think my colleague from Israel, he's smiling. I think he should know a lot about the Monica study also. But you see, makes sense? Yes. Rich people always lived longer since the human being is on the face of the earth, right? This is not because of ACE inhibitors, ARBs, beta blockers, okay? Maybe lots of money issue, but not only money issue. So this is the key message from the Monica project. This is the truth of the matter. We do not yet know for sure. Hello, Philip, you can interrupt as long as you wish, okay? We do not yet for sure why cardiovascular mortality started to globally decline since the 60s, independent of antihypertensive treatment. Probably this is multifactorial, but seems to be a crucial role for socioeconomic and educational factors. So we need to have money, and we need to be educated. Makes sense? Yes. But we don't know for sure what are the factors. For sure, not so much the traditional cardiovascular risk factors. This is good for the pharmaceutical companies to make their advertisements. So let's talk a little bit more about diabetes. People do not talk too much also about this. Is the focus okay, Ricardo? Ricardo, is the focus here okay? Manage anything if you wish. I think it's fine for me. This is the UKPDS 38, published in 1998 or 1999 at the British Medical Journal. It was divided, most was at the British Medical Journal, other ones were in the Lancet, the UKPDS, which is the best diabetic prospective study we have on the face of the earth. The old UKPDS. And people do not talk too much about this. they prefer to talk about the less DPP-4 inhibitor, the less insulin analogs, but they do not like too much to talk about the UKPDS38. They don't like to talk with me, at least, okay? What it has shown, okay? Tight control of blood pressure with captopril or atenolol with other agents needed as necessary. Look at the goal, to a blood pressure below 150/85. Achieve this mean, not that low, you see? They want us to give tons of medications to our patients. As Philip said, not that they could not stand up anymore, you know, to have sex with their wives, even less, you know, if you have very low blood pressures. Okay, but %29 of the patients require 3 or more antihypertensive treatments. But let's see what else it showed. You should take care of this name, UKPDS38, okay? People don't like too much to talk about it. Tight control of blood pressure reduced the risk of any non-fatal or fatal diabetic complication, and that related to diabetes. Retinopathy was also reduced. So reducing blood pressure needs to have a high priority in the care of any type 2 diabetic patients. Much more than glycemic control. Good blood pressure control, but not with lots of medications. Having a good statin that makes not the muscle of your patients go away. They make more difference. So then it came the UKPDS39. My friend from Israel, he's smiling. I don't know what he's thinking. I get afraid of him. But you please do not mess with me too much. Then it came the 39, comparing captopril, a fashion drug, at that time an expensive drug, with atenolol, a drug for poor people, you know? One of the worst beta blockers was the UKPDS39. So, I'm sorry there was a mismatch of slides. So, about the UKPDS38, this is important for you to remember. People don't like to say that too much. Blood pressure control, I'm sorry here, is the single most effective measure for preventing diabetic complications. This is the truth of the matter, much more than glycemic control, for example. So far, a blood pressure goal of less than 100/85 has the best available evidence for those people who have over 6 years old of age, which is the most growing population of diabetics all over the world. I think even in Africa, perhaps even in Afghanistan, I don't know. So, this was UKPDS39. I'm sorry about this, but you can see less tight control, more probability of events, and tight control with captopril and atenolol, no difference, okay? So it makes no difference. If we put that on a meta-analysis format, we see all of them cross the line of 1, so there is no statistical difference about the confidence intervals. I hope I'm being clear here. Yeah, but so these were the key messages. There were no difference about captopril or atenolol regarding the prevention of diabetic complications as long as blood pressure was lower. Not too much lower, reasonably lower. Okay? The two drugs were equally effective. Interesting that, right? We are always looking for a wonder drug, a darling drug, right? We doctors, we like that. We like miracles. People who took atenolol had a little more weight gain, a little higher HbA1c, but you see, no impact, no clinical impact. So, the suggestion that angiotensin-converting enzyme have a specific renal protective effect in the treatment of type 2 diabetes is not supported, which I fully agree, you know. We have to stop those wrong dogmas in medicine. So the key message here with the UKPDS 39 is there is no wonder drug for hypertension treatment. What is paramount is to get the blood pressure to the best targets and goals to your patient. I prefer the word goals. Okay? What matters is to lower your blood pressure the amount you wish. Okay? To your individual patient. The guy from Turkey is sleeping, so I must hurry up here. No, not sleeping, okay. So it came the Accord blood pressure trial, okay? That was an open label trial, not good, and has a lot of selection bias. You see, I brought it into Washington, D.C., and I was discussing this with the authors. Was a very much highly publicized clinical trial, multimillionaire clinical trial. By the way, people who had good or excellent blood glucose control, they had a lot more deaths in this study. But you see, they excluded, I was talking with them, everybody with higher than 70 years old, those who were very much obese, those who had a serum creatinine of 1.5 or higher, those who were dyslipidemics, who went to the arm of dyslipidemia, those who had a systolic blood pressure above 180, and allowed the free use of statins and antiplatelets. So I told the guys in Washington, D.C. at the Council for High Blood Pressure Research, these are not the diabetics that I see on my clinic. And they publish in many journals that the Accord blood pressure were on high-risk type 2 diabetic studies. I see if I exclude all those patients, I will not have a high-risk type 2 diabetic population. This is a very strong selection bias. So what I did, I took a very, let's say, simple but reliable tool. This is the JADAD score. It was created in Oxford, okay? It's simple and reliable, okay? Well validated. You see, when a randomized clinical trial is not double-blinded, it loses points here, you see? And I wrote an abstract and presented there, okay? So this was the abstract. This young fellow here is this young boy here, that's myself, okay? This was in Washington in 210. This was my conclusion that within the context of a low-quality clinical trial, because it was highly publicized that it was a negative trial, I thought it was a positive trial because there was a reduction, at least in stroke, in those who had an intensive blood pressure control. but they were very healthy diabetics. Do you agree with me? With all those exclusion criteria, they were quite healthy diabetics, very different from my diabetic patients I see on my outpatient clinic. So, by the end, look at the last. So I was proposing prospective, larger, double-blind, randomized clinical trials with better generalizability, with less selection bias, to target a lower blood pressure control in patients with type 2 diabetes would be necessary. They have never done it. Let me tell you something. 120/80 can be good if you are very much healthy guy. If you have some comorbidity, it's much more difficult to achieve without side effects that are not good. They are not cost effective. If you are a completely healthy guy, that's fine. Do we have an example of this? Yes, we do have. It was published in 2008 in the New England Journal of Medicine. We see beautiful things nowadays. You see, Beatriz, when I was there at Harvard, we didn't see so many beautiful things at the New England Journal of Medicine. It was the HIVET study. They took 10 years recruiting people with hypertension over 80 years of age. So it was wonderful, wonderful. So it should be really lower blood pressure in the very old. But they were all healthy elderly people. You know, they took 10 years to recruit all those people. Those people, they can tolerate lots of things. I do not believe that people with comorbidities, which is most of my elderly patients, most of my elderly patients have hypertension and type 2 diabetes, hypertension and Alzheimer, hypertension and stroke and previous stroke, hypertension and porphyria, for example, and so on. They are not healthy, okay? Most of my patients have comorbidities. I'm almost finishing, okay, Ricardo? Thank you. So the key message here, we cannot draw consistent conclusions from a low-level clinical trial like it was the ACCORD. We do not yet know the best blood pressure goal for low or medium cardiovascular risk type 2 diabetics because the ACCORD population was not a high-risk cardiovascular risk population. Perhaps a stroke advantage with lower BP goals for those very much healthy guys over 60 or 65 years. Maybe. But will it be cost effective? It's good to give 3 drugs only for hypertension to your diabetic who will take an statin, who may sometimes have Alzheimer's disease and other things. I don't know. Really, I really don't know. Maybe increase his salary, right? What do you think? Better, right? So these are my 2 last slides. Final take-home messages. The first one, do not scare your patients. Oh, you have hypertension, you're going to die soon. No, not like this. This is a very common disease. It's a chronic disease with good sense, and you can handle well this disease, okay? Do not panic your patients. You have to build empathy with them. Share the decisions with the owner of his health, which is the own patient. Your patient is the owner of his health. You should not put delusions on his mind. We have this miracle drug. We have this wonder drug. We have this darling new drug. This does not exist. I do not believe on this. And there is no wonder or darling drugs for hypertension treatment. Come on, Philip, you can contest me, okay? And you need to know that this exists. Take a look at the Google, take a look at this publication. This exists. And if you are in doubt, nowadays we are lucky. We are having two good guidelines, I'm sorry, two good. It's the GNC8 and the NICE guidelines for the European Society, for the British Society of Hypertension. These are good ones, but forget about this. This is a 14 pages, very well written, no conflicts of interest. This is a 73 pages, lots of conflicts of interest, lots of millionaires, doctors who makes lots of money from pharmaceutical companies. And that's it. Thank you.